Right now, you are probably swallowing.
Yep.
You'll execute that exact reflex around 600 times today, and mostly without a single conscious thought.
It's totally automatic.
Right, but what happens when that automated, perfectly timed sequence becomes a lethal threat? Welcome to a brand new deep dive. We are exploring the hidden high-stakes physics of the human airway today.
And we're being guided by a really highly technical framework for this one.
Yeah, we are. We're looking at chapter 122 of a medical textbook, Decision-Making in Otolaryngology, and the chapter is just titled simply Aspiration.
Which centers around this massive branching decision tree flowchart.
Exactly. So our mission today is to translate that clinical algorithm into, well, an understanding of how the airway fails, how physicians kind of play detective to hunt down the source of the leak, and the intense medical engineering required to restore the system.
Right. And the entire algorithm is built on this totally uncompromising philosophy, introduced in the very first paragraph. The absolute primary mandate is the cessation of aspiration. You have to protect the pulmonary system and ensure safe enteral feeding.
Which makes sense. I mean, you need your lungs to survive.
Exactly. There's a secondary goal, which is the preservation of phonation, or speech. But the text draws a very hard line in the sand here.
Yeah, they do not compromise on that.
No. Preserving a patient's ability to speak can never ever come at the expense of their pulmonary survival.
It's basically the ultimate triage of human function. I was thinking about it like, okay, if you're remodeling a house, you have to secure a crumbling foundation before you wire in the luxury stereo system.
That's a great way to put it.
Right, like speech is a profound part of the human experience, obviously, but from a purely physiological standpoint, it's a luxury feature. You have to secure the basement first.
You really do. But identifying that a patient is aspirating in the first place isn't always straightforward.
No, not at all. When you look at the diagnostic protocols outlined in the chapter, it feels less like a standard medical exam and more like forensic accounting.
It really requires an aggressive level of clinical suspicion. Because the challenge with diagnosing aspiration is that you are trying to capture a dynamic, moving target.
Yeah, it's not just a static broken bone.
Exactly. The text points out that a standard modified barium swallow, video fluoroscopy,
Which is basically a moving x-ray, right?
Right, that scan can be entirely normal, and yet the patient might still be experiencing episodic aspiration.
Which is wild to think about.
Well, they might protect their airway perfectly while sitting up in a radiology suite, fully alert, swallowing contrast dye on command, but then they aspirate their own secretions 2 hours later while lying flat in bed.
So basically, a clean scan doesn't clear the patient.
Not at all.
If the video fluoroscopy misses it, the algorithm points us towards something called FEES, that's fiber optic endoscopic examination of swallowing.
Right, which involves passing an endoscope directly through the nasal cavity.
Yeah, so it allows the doctor to visualize the glottis in real time while the patient manages regular food and even just their own saliva. But the text also brings up salivary scintigraphy, which I thought was fascinating. They're tracking a radioactive isotope placed in the oral cavity.
Scintigraphy is particularly brilliant for identifying the source of the issue. Placing a radiotracer in the mouth and then scanning the lungs hours later gives you definitive proof.
Proof of whether a patient is silently inhaling their own saliva over time.
Exactly. And that concept of silent aspiration is a major red flag throughout this entire chapter.
Because we tend to associate aspiration with, like, a violent coughing fit. Someone chokes at a restaurant and everyone notices.
Right, but neurologic impairments or altered states of consciousness can completely blunt the afferent sensory loop in the larynx.
So the fluid drops straight past the vocal folds into the trachea and the patient doesn't even flinch.
The alarm system is entirely disconnected.
That is terrifying. And it makes the clinical exam critical because you can't just wait for them to cough. You have to actively evaluate the cranial nerves and watch the laryngeal elevation.
Yes, the structural ascent of the larynx is what tucks it under the base of the tongue during a swallow.
Right, it physically moves up and out of the way. And if those mechanics are sluggish, the airway is just left exposed.
So looking at the structure of the textbook's flowchart, the diagnostic pathways diverge almost immediately into 2 distinct clinical realities.
Yeah, the left side and the right side.
We have pediatric presentation and the adult presentation. And the distinction isn't just about age, it's about the fundamental etiology of the failure.
I see it as the difference between assembly errors and system degradation.
Oh, that's a good distinction.
Let's explore the assembly errors first. So, in the pediatric branch, we are looking at congenital anomalies and early neurologic deficits.
Right, things like premature birth, a history of poor sucking and frequent gagging, those point towards structural miswiring.
Like cleft palates or a bifid larynx, or a tracheoesophageal fistula, which is where the respiratory and digestive tracts are literally physically cross-connected.
You also see the profound impact of cerebral palsy or other neurologic impairments here. The neuromuscular coordination simply never develops correctly.
Which leads directly to a prominent clinical challenge in the pediatric algorithm, and this surprised me: severe coeluria.
Drooling.
Right, chronic drooling might seem benign, kids drool, but in a neurologically impaired child with a compromised swallow, pooling saliva is really dangerous.
It represents a constant reservoir of fluid resting right above an unprotected airway.
So the clinical progression for treating coeluria here is fascinating. The text adheres to a strict, minimally invasive first mandate.
Which is standard, you start with positioning, using gravity to your advantage by keeping the child upright.
And you manipulate the diet, right? Thickening feeds so the fluid moves slower and it's just easier for them to control.
Right. But when conservative measures fail, the algorithm dictates pharmaceutical intervention, and specifically injecting botulinum toxin into the major salivary glands.
Wait, Botox? They inject Botox into the glands?
Yes. It is an incredibly elegant application of a neurotoxin. Botulinum toxin blocks the release of acetylcholine at the neuromuscular junction.
Right, which is how it stops wrinkles by freezing muscle.
Exactly, but it also blocks the cholinergic innervation of the exocrine glands. So by injecting the submandibular and parotid glands, you are chemically denervating the tissue.
You're dramatically downregulating saliva production.
You're literally drying up the threat to the lungs.
That is amazing. And if that chemo denervation doesn't hold, the surgical escalation is, well, it's pretty intense. It involves bilateral excision of the submandibular glands.
Just taking them right out.
Yeah.
Or rerouting the parotid ducts posteriorly.
So the saliva drains further down the pharynx, totally bypassing the immediate laryngeal vestibule. Okay, before we transition to the adult branch, I definitely want to highlight a massive caveat the authors place in this pediatric section regarding gastroesophageal reflux.
Ah, yes, the warning about fundoplication.
Right. So if aspiration is suspected to be secondary to severe reflux splashing up from the stomach, a Nissen fundoplication is often considered.
It's a surgery to tighten the lower esophageal sphincter. But the authors explicitly state that reflux must be definitively confirmed as the primary etiology before attempting this.
Because the mechanics of getting that diagnosis wrong are just devastating. If a child has a primary swallowing disorder causing them to aspirate from above,
from the mouth.
Right, and you surgically tighten the exit valve at the bottom of the esophagus with a fundoplication, you trap the fluid.
Whatever they swallow now hits a high pressure barrier at the stomach.
It backs up into the esophagus and spills massively over the top into the airway. You take a bad aspiration situation and make it catastrophic.
It really highlights why accurate diagnostics are paramount. Treating the wrong end of the pipe makes the leak exponentially worse.
It really does. So shifting focus to the adult side of the algorithm, the etiology changes. We move away from congenital defects and confront anatomical obstructions that develop over time.
Right, things like esophageal webs and strictures. They create physical barricades, altering the flow dynamics.
And causing retrograde spill into the larynx. Zenker's diverticulum is a perfect example of this acquired structural failure.
Oh, absolutely.
It's where a mucosal pouch herniates through a weak point in the posterior pharyngeal wall, usually because the cricopharyngeus muscle fails to relax properly during a swallow.
So that high pressure just blows out a pouch.
Yeah. And the hallmark symptom listed in the text coughing well after a meal is finished is chilling when you picture the mechanics of it.
Well, the diverticulum acts as a reservoir. The patient swallows, and food and pills pack into that unnatural pouch.
And the patient thinks the meal is over. They're done eating.
Right. Then they lie down or even just turn their head. The mechanical compression empties the pouch, dumping undigested material directly into an airway that is no longer bracing for a swallow.
That's terrifying. Structural issues like a Zenker's can be surgically resolved, though. The far darker reality in the adult branch deals with progressive neurodegenerative diseases.
Yes, ALS, Parkinson's, multiple sclerosis.
These conditions systematically dismantle the complex cranial nerve networks required for a safe swallow.
And the neuromuscular decline is just relentless. As the pharyngeal constrictors weaken and laryngeal elevation diminishes, conservative therapies inevitably fail.
Because thickeners and positional changes cannot compensate for a completely flaccid or uncoordinated swallow.
Exactly. The pulmonary system becomes constantly inundated with debris, leading to recurrent, life-threatening pneumonias.
Which brings us to the endpoint of the algorithm for irreversible intractable aspiration. When the cranial nerves are dying, the clinical intervention requires the ultimate anatomical sacrifice.
Laryngotracheal separation or a total laryngectomy.
Returning to our initial philosophy from the start of the deep dive, this is the final, extreme manifestation of protecting the lungs at all costs.
The surgeon physically divides the airway from the digestive tract. The trachea is brought forward and sutured directly to the skin of the neck, creating a permanent stoma.
And the pharyngeal defect is closed, so the anatomical intersection where food and air normally cross paths is permanently abolished.
The respiratory system becomes an entirely closed loop from the neck down.
Which makes swallowing perfectly safe again because there's literally no anatomical pathway for food to reach the lungs anymore.
Right, but the cost is a complete permanent loss of natural phonation. Air no longer passes through the glottis.
It is a profound surgical intervention. It really underscores the sheer survival priority of pulmonary function.
It does. But, while neurodegeneration demands extreme anatomical separation, the text also details situations where the airway simply requires highly targeted mechanical engineering.
Right, because many aspiration events in adults are the result of specific, isolated structural deficits.
And the textbook section on the aerodynamics of the airway is phenomenal here, particularly regarding tracheostomy tubes.
Yeah, that part was wild to me. The flowchart lists an existing tracheostomy as a primary cause of aspiration. To anyone outside of critical care, that sounds like a paradox.
It does. A tracheostomy is supposed to secure the airway.
Right. So how does a breathing tube induce aspiration?
Well, you have to view the pharynx and trachea as a pressurized aerodynamic system. During a normal swallow, the vocal folds close tightly and the lungs compress slightly, creating a pocket of subglottic pressure.
And that upward force acts as an aerodynamic cushion beneath the vocal folds, right? Helping to deflect descending food and liquid laterally into the esophagus.
Precisely. But a tracheostomy tube punctures that closed system. You vent the pressure directly out the anterior neck.
So you lose the subglottic cushion.
Gravity takes over and oral secretion slides straight down past the glottis.
And furthermore, because the patient cannot build up intrathoracic pressure against closed vocal folds, they lose the ability to generate a forceful, expulsive cough to clear the debris.
Right. But the biomechanical solution is incredibly elegant. It's called the Passy-Muir valve.
Yeah, the text explains it's a one-way, biased closed expiratory valve attached to the hub of the tracheostomy tube.
It opens seamlessly during inspiration, allowing air into the lungs, but snaps shut instantly upon expiration.
So the exhaled air is forced to travel back up the trachea, through the vocal folds, and out the mouth and nose. It instantly restores the physiologic pressure gradient.
The subglottic cushion returns, dramatically reducing aspiration risk.
And the patient regains both phonation and the ability to produce a strong, productive cough. Fixing a complex aerodynamic leak with a simple mechanical check valve, it's brilliant.
Another isolated mechanical failure detailed in the text is glottic incompetence, which most commonly presents as vocal fold paralysis.
Right, the recurrent laryngeal nerve is injured, maybe during thyroid surgery, leaving one vocal fold paralyzed in a lateral or paramedian position.
It's like an elevator door permanently stuck open.
Exactly. When the patient swallows, the glottis cannot seal. The protective barrier is compromised, and fluid pours down the open shaft.
The surgical interventions for this, vocal fold medialization, are just an amazing study in biomaterials and physics.
You are physically plumping the paralyzed fold, right? Pushing it toward the midline so the healthy mobile fold can meet it and seal the gap.
Yep. And the choice of material depends entirely on the prognosis of the nerve injury. If the paralysis is acute and there is potential for spontaneous reinnervation, you require temporary medialization.
Like injecting gel foam, which provides excellent bulk, but resorbs in about 4 to 6 weeks.
Or hyaluronic acid, which is another excellent temporary option.
Yeah.
It provides a slightly longer duration of medialization while you wait to see if the nerve recovers.
But if the nerve is severed, or the paralysis is deemed permanent after a year of observation, the algorithm shifts to permanent injectables.
Using calcium hydroxylapatite provides a stable, long-lasting structural bulk. The text also highlights the harvesting of autologous adipose tissue.
Which is extracting the patient's own abdominal fat, processing it, and injecting it directly into the paralyzed vocalist muscle.
It is, but it's also vital to note what the algorithm explicitly rejects.
Oh, Teflon, right?
Yes, Teflon was historically used for permanent medialization, but has been universally abandoned due to severe foreign body reactions and granuloma formation.
And if injection laryngoplasty isn't sufficient, the surgeon will proceed to an Ishiki type 1 thyroplasty, which is pure structural mechanics.
Totally. You bypass the needle, make an incision in the neck, and carve a precise rectangular window directly through the thyroid cartilage.
And then you insert a customized elastic block or a Gore-Tex implant. You physically wedge the paralyzed vocal fold into the midline from the outside.
You are permanently resetting the architecture of the larynx. The healthy fold compensates, sweeping across the midline to meet the wedged fold.
Which restores the glottic seal for both swallowing and phonation.
Exactly.
Tracing the entirety of Chapter 122's flowchart reveals a remarkable spectrum of clinical problem solving. I mean, we navigated the diagnostic challenges of silent aspiration using radioactive isotopes.
We examined the congenital miswiring of the pediatric airway and the targeted use of neurotoxins to dry up salivary reservoir.
Right, the Botox. And we confronted the grim reality of neurodegenerative decline, where the preservation of the lungs ultimately requires the sacrifice of the voice.
And we explored the biomechanics of restoring aerodynamic pressure and manually wedging open glottic gaps with celastic blocks and autologous fat.
The human airway is a masterwork of evolutionary engineering, demanding equally brilliant interventions when its tight tolerances begin to fail.
It really is. And the complexity of these interventions makes one specific, understated box on the far right of the algorithm profoundly resonant.
Which one is that?
Well, under the etiologies for aspiration, there is a small node labeled simply pharmacologic. The text notes that any medication that depresses consciousness or compromises neuromuscular function can precipitate aspiration.
And the indicated treatment is simply to discontinue the offending agent.
Right, but the implication of that single box is massive when applied to a modern population.
Oh, definitely.
Consider the sheer volume of prescriptions dispensed daily for severe sleep aids, anxiolytics, sedatives, and muscle relaxants. These pharmacologic agents are specifically designed to depress the central nervous system and induce deep, artificial relaxation.
They're systematically blunting the very apparent sensory loops we discussed earlier. The internal alarm system of the larynx is being chemically sedated.
It forces a highly uncomfortable clinical question. How many individuals are experiencing chronic nocturnal microaspiration?
Wow. Minute volumes of saliva, laden with floral bacteria, silently slipping past overly relaxed vocal folds into the pulmonary tree night after night.
And they never wake up choking. The cough reflex is entirely suppressed.
So the chronic pulmonary damage is accumulating entirely under the radar, driven by the perfectly legal prescribed medications sitting on their nightstands.
Right, we study these intricate surgical algorithms, prepare to harvest fat and sever tracheas to protect the lungs, while millions of people are voluntarily dismantling their own airway defenses every single night.
That is definitely something to think about before you take that next sleep aid. A profound thank you to the authors of Chapter 122 for mapping the clinical limits of the human airway. And thank you to everyone listening to this deep dive. Question your assumptions, protect your algorithms, and we will see you next time.